presentation. I'm Nagar. I'm an event coordinator here at Generation Science, and today we're going to be talking to Miss Toni Luongo. I'm sorry, am I pronouncing that right?
Yep, that's correct. Toni Luongo.
Awesome. She's a physician assistant student at McMaster University with a Bachelor of Science and Honors Biochemistry, and she's done a lot of research under Dr. Eliane Ratcliffe investigating the role of cannabidiol on colonic motility in early life. So today we get to listen to her talk about her work. Thank you so much.
Not a problem. Thank you so much for having me. So everyone just kind of bear with me today. So the presentation that I'll be giving today, I can talk a little bit about the research that I've done in my undergrad, but the presentation I'll be giving today will be all about social determinants of health and access to healthcare. So without further ado, I will start sharing my screen. All right. Share. All right. And let's see. Slideshow. Play from start. Okay, perfect. Is everyone able to see my screen right now? Okay, great. All right, so as I mentioned before, the topic I'll be talking about today is social determinants of health. And basically we're talking all about the effect of socioeconomic status and how that affects healthcare access. So as Nagar was saying, my name is Toni. I do have a Bachelor of Science in Honors Biochemistry, as well as I minored in Psychology. I did my undergrad at McMaster University, and as well, I have just began the Physician Assistant program at McMaster as well. And if you have any questions throughout the presentation, please feel free to raise your voice, interrupt, use the little reactions to raise your hand, whatever you feel comfortable doing. And I'd be happy to answer any questions that you might have. As well, if after the presentation you have any questions for me that you may not have wanted to ask via this platform, you can also reach me on Instagram at the Ontario PA. My handle is at the bottom of the screen. And I'm also very open to answering any questions you have, whether it be about the role of PA, whether it be about social determinants of health, or really just want to chat or say hi. I'm totally open to it. So many of you might be wondering, what is a physician assistant? What is our scope of practice? What do we do? Why did I choose this? Who is this person? So they're all really great questions. So before I dive into a little bit about what a PA can do, I'll tell you how we define a physician assistant. So physician assistants, we are seen as medical extenders. We are hired by practicing physicians, those that hold an MD degree, and we are seen to extend their breadth of healthcare expertise. So essentially, when we get hired by a physician, we are thought to have the same equivalency or medical knowledge as a medical resident. So what that means is when we graduate our program, we are seen to have the same education equivalency that an individual graduating from the MD program would have after their 4 years, except the difference is we graduate in 2 years. So there's a few differences there. As well, when we are practicing as physician assistants, we are not seen as autonomous healthcare providers. What this means is that we do operate under the direction and the medical directives and the scope of practice as the hiring physician that we're working for. This doesn't mean that we must see patients with our physician. We have the autonomy to see patients on our own, to do our regular daily activities that our job would entail. However, it just means that on paper, we are practicing under Dr. So-and-so. As well, we do a lot of like inter-health team like consults, in that perhaps at the end of the week, I would meet with my supervising physician. We would go through cases, things like that. We talk about certain like expectations that the healthcare practice has on me, and then we can go from there. As well, something that's really great about a physician assistant is even though we're able to provide healthcare to patients, if we ever come across perhaps like a complex case or something that we're unsure about, we always have that supervising physician to kind of resort to or lean on if there's any time of uncertainty. And it's really great because in the role, although we start working right after we graduate physician assistant school, it's also medical school. We do fall under the Faculty of Medicine at McMaster. Um, when we do graduate, essentially we start practicing right away. There's no need for us to undergo residency. We don't need to be matched at all for residency. We don't need to do a fellowship. Once we graduate, we write our certification exam. Once we pass that, we can become hired as physician assistants and start practicing medicine. So some people might be wondering, okay, you might not be seen as autonomous, so what can you do? What is your scope of practice? Essentially, like what healthcare can I provide to a patient? So essentially, when we think about scope of practice, it's really just what we're able to do. And the great thing about a physician assistant is our role is very flexible. Currently in Canada, only 1 or 2 provinces have actually regulated the role of the physician assistant, which means that the government has a say in how we perform our duties. But the provinces that are non-regulated or where PAs are non-regulated, that means that what our scope of practice looks like is dictated by who hires us and what our physician's scope of practice would be. So every contract that a PA and their physician has looks a little bit different. But for the most part, our scope of practice can range between, education of patients. So if a patient comes in and they need diet counseling, or if we need to encourage like smoking cessation, like informing them of all of the, I guess, risk factors or things like that, we can definitely do that with patients. We also can conduct patient histories. So when we do intake appointments with patients, when a patient comes in with just any chief complaint to us, we can conduct a history, find out what's going on, what they need from us, and how we can possibly help them. We can also perform physical exams. So those stethoscopes, although they hang around our neck and they look like they're just for show, we use them when we're doing physical exams on patients. And they range from all different body systems that we're trained in. As well, we can order and interpret medical investigations. So that means we can send patients to get blood work done, ultrasound imaging, x-ray, anything that we need that's further from the physical exam and the history to help us put together the pieces of that medical picture of the patient. That's what we can do. As well, people might think, okay, so she works under a physician, but we do have clinical and diagnostic skills, which means that we are able to formulate treatment plans. That means that when a patient comes and sees us, we can outline the course of treatment that is appropriate for the patient, and we can even diagnose and prescribe medications. We can refer them to specialists. Anything that the treatment plan would entail, that's what we can do. As well, depending on what your area of practice is, whether you're a physician assistant in the emergency room, a family medicine clinic, hematology clinic, that's really great because your role is also flexible in that setting. So for example, if I am a physician assistant in the ER, I would actually find myself doing suturing or, irrigating wounds, things like that. So we can perform medical procedures. As well, we are able to assist in surgeries. So there are many physician assistants that do work in surgery, which is, it honestly, a lot of people have talked about working with their PAs, especially in surgery, and we do help to make that process go by more efficiently, more effectively. And so we can either assist in surgery directly in the OR, whether that be with whatever operation the patient is undergoing, or we can help with pre-op and post-op care with patients as well, and also arrange with follow-up procedures. Now, before I go on to talk about, why I pursued this pathway, does anybody have any questions? You can feel free to type it in the chat or raise your voice, whatever you're comfortable with. All right. If there's no questions, so some people might be wondering, so why did I pursue the path of PA as opposed to a nurse or pursuing my MD degree? And that's a really great question. My history is a little bit, I guess it's very similar to a lot of what PAs out there now have kind of come across. For the longest time, I was kind of on that like MD mindset. I had no idea what a PA was for the majority of my undergraduate degree. Never heard of it, didn't know they existed, didn't know they were in medicine. I thought the only way that I could treat patients, help patients, and do all of that fun stuff was if I pursued a medical degree through the MD program. However, when it came down to applying to, medical school, it never felt kind of right. It never felt like the perfect fit for me. There were a lot of factors into play that I didn't really think about when I was in first year or second year. Like there's a lot of like administration that doctors have to do, running your own clinic. That's a huge responsibility. The sheer amount of time that they spend in school before they can start, practicing and being that like head of any healthcare team. That's a lot of years, being matched for residency, not being guaranteed a match for residency, having to undergo fellowship before you can actually take on that role as an attending. There's so many different factors, plus the continuous competition. It was a lot. And I do know people that got into the MD program, and I kind of talked to them about it. I talked to my supervising PI when I did my undergrad and I did my thesis work with her. She worked in pediatric gastroenterology. And we were kind of just having a chat one day, and I was kind of telling her about how I was feeling, what I really wanted out of medicine, what I really wanted out of myself, where I saw myself. And she just kind of suggested to me, okay, I know this girl, she worked for me like a few years ago, and she is a physician assistant at, Mac Children's Hospital. And I was like, I've never heard of that role. And she was like, she set up a time for us to meet. We grabbed coffee and she got to tell me all about her job. And it was like all of the pieces had fit together. And I knew that that was where I had to be. Luckily, this happened 3 months before applications for PA school opened. So I applied. I got an interview to McMaster's PA program. I only applied to U of T and McMaster. There's also another PA school in Canada, which is in Manitoba. So there's a total of only 3 PA schools in Canada. And I only applied to the 2 in Ontario. Got an interview to MAC. No idea how that happened. Got in. Still don't know how that happened. And now we're here. I am just finishing up my second semester in my first year of PA school, and there's 3 semesters in first year. And then off in second year, I'll be starting clerkship. And I couldn't be more happy with my decision. It really feels like a great fit. The community is so warm and welcoming. My class is also really, really small. There's only 24 of us, actually 23 now. We had to have someone who dropped out just for personal reasons. So there's 23 of us. Almost 1,000 people apply every year. So it is still very competitive as getting into an MD program. But yeah, I couldn't be happier. And one of the really great things about PA school is our curriculum is very multifaceted. We are putting such a heavy influence and such a heavy emphasis on, learning the medicine, learning about disease pathology, learning about physical exams. But one thing that I really love about the curriculum, I can't speak about other curriculum at other schools because I'm only attending MAC, but one thing I love about our curriculum is we have this course called Professional Competencies. And in our professional competencies class, we get to talk about medicine outside of the science. And I think that is one of the most valuable things so far, other than all of the great things of learning to be a physician assistant. I think it's so valuable being able to take a step back from all that science and all that heavy studying and really get to learn about, consent. What does consent look like? What is our limits of confidentiality as a healthcare practitioner? And as well, something really important, which I'll be talking about today, are social determinants of health and how that affects patients. So if we're talking about social determinants of health, there are so many of them. Currently, right now, there's actually, according to all Canadian resources, there are 14, sorry about that. There are 14 social determinants of health. So essentially, we'll only be focusing on the one today, and that's more so income, social status. But there's income and social status, which is a social determinant of health, employment and working conditions, education and literacy, childhood experiences, physical environments, social supports and coping skills, healthy behaviors, access to health services, biology and genetic environment, gender, culture, race, and racism. Well, race and racism are kind of tied into the same like social determinant. So basically, what we can think about is there are things that exist in every healthcare system. No healthcare system is perfect. There are policies and procedures that are in place that actually tend to marginalize and actually exclude certain individuals based on their social determinants of health. So one thing to acknowledge is that there's this thing called health inequalities. And the way that that's defined is it's defined as differences in the health status of individuals and groups. And health status is really just a fancy way of saying ways that we can access healthcare as a whole. So although we'll be talking more so about, socioeconomic status as a social determinant, keep in mind that when we see a patient, let alone keep in mind that every patient we see, we are automatically assuming that they are privileged enough to seek healthcare. So there are so many people out there that might not even have access to healthcare because of their social determinants. So on to socioeconomic status. Here are just some statistics out there. So essentially, out of 7.2 million Canadians that are aged 15 and over, they have reported having a disability as well. That would be about 13%. Sorry, my brain is scattered after a very long day of studying. So 13% of those 7.2 million Canadians aged 15 and over reported having a disability or reported experiencing hidden homelessness. As well, something that we commonly hear about in our studies is Indigenous peoples. They are more than twice as likely to experience hidden homelessness and their non-Aboriginal counterparts. So something that we talk about a lot in our professional competencies class is essentially the fact that we do talk a lot about the Indigenous peoples just because their entire history throughout, from the time that they came to, that they were already settled in Canada, and then basically that their land was taken away. That history going back all of these years is still affecting Indigenous peoples today. And one thing I also really love about our professionals competencies class is we invite individuals that are so experienced and they have so much information on just like what are, what is the correct terminology when referring to people, Indigenous peoples. That is something now that is socially acceptable to say. We're kind of straying away from the term Aboriginals, but I've just left that on the slide because it is just a term that I wanted to mention is being, filtered out as we go on. As well, we were talking about, this was a big topic when we talked about race in healthcare. We were wondering, like, is it okay to call someone Black? And it's me being a privileged white heterosexual female, me saying that word almost feels like I'm not allowed. But what we had in our presentation was we learned that that term actually was reclaimed by the people of the Black community. And it's now a term that is more so empowering. So I thought that was really great and just a fun tidbit on just terminology. And that also, race, ethnicity, how we identify, those all come into play when it comes to accessing healthcare. So the way that we can think of as socioeconomic status, how does that work? How does it start? How does somebody go from being born to ending up on the streets, or being born and bouncing in and out of different shelters or different support groups, or even just relying on government funding? Because socioeconomic status is nowhere near a compartmentalized like word. It is all on this large sliding scale, and it really just varies. People, you think about socioeconomic status and a lot of people think of the poorest of the poor, but there are some people that, you can't see it. You don't see what they go home to every day, or if they go to a home every day. And so that's really important to note, is that sometimes we will be seeing patients who are living out of their car. That's an example. or we'll see patients that, you know, are bouncing in and out of different like facilities that provide semi-permanent housing or temporary housing. It really depends. So one of the ways that we can kind of think about socioeconomic status, it's unfair to say that this is the only way that it happens and the way that needs aren't met in healthcare, but essentially what happens is we can kind of think about it as an individual acquiring some type of injury or illness. And as I was talking about, there are so many imperfect systems that tend to marginalize and further reduce the accessibility of services for people every day. So oftentimes, if you think about it, someone is injured, they have to take time off of work. Does their job provide them with compensation if they are injured or have illness? Some illnesses by some job places don't view them as an actual illness. This is just like an example that's used very often, but for example, mental health and mental wellness and mental illness. That's also a spectrum. I won't get into it, but let's say someone is identifying with issues pertaining to the mental health illness category. A lot of employers do not consider this a acceptable reason to take time off of work. And as a result, this can result in them not being able to find work or maintain stable jobs. And without a stable income, essentially they're out of, house, a home, they can't keep up with the daily expenses of living, keeping up rent, and even accessing medical care. So one thing that was actually really interesting that I've learned about in our class is we actually talked about refugees. We talked about refugee status and how our role as PAs and how we provide them healthcare actually changes based on their refugee status. When I say that the way we provide them healthcare changes, I don't mean that the quality of care that we provide them is any greater or any less, but rather there are many considerations that we have to take into account when we're seeing someone with refugee status. So that's just something that I'm just using this as an example. And many people that do have refugee status might also struggle with the socioeconomic status and that social determinant of health. So as well, many social determinants of health, they see that intersectionality. There are many individuals that might struggle with one of the social determinants, but oftentimes when one of those is affected, there are many others that come into play because unfortunately, it's almost like a domino effect. When one thing is kind of, removed from the picture, everything else seems to suffer in terms of like compensation. It's all compensating for each other. And as well, it has to do with how they're viewed in society and how they're treated. So back to my example, just about like refugees. So we actually learned, I believe feel free to correct me if anybody knows, but I believe it takes about 3 months to actually obtain refugee status. And so they actually get a special, it's not a health card because it's not an OHIP card, but it's a special like card that shows that their healthcare is being covered by, I can't remember what the funding is, but their healthcare is basically covered under a support for refugees. So one thing as well, that's how we kind of are able to, because it's no surprise, healthcare is not free, but that's what we use to charge, refugees through. But a lot of scenarios that we went through in our class was, what if we have someone who recently came to Canada and they haven't had that card? How do we provide them care? And there are ways around it. There are different grants and there is different funding, and that's something to keep in mind. But you can already imagine how someone must be, like what frame of mind they must be in, having to flee their country, having to leave everything behind, having to leave perhaps family, their home. We even talked about people that fled from like war-torn countries. And it really changes the way that we provide care because there's so many other factors to these multifaceted individuals, as we all are, that we really have to keep into consideration. We learned there was a statistic actually when providing care to refugees, and we take that initial history, the patient history, figuring out, what's the chief complaint, all of that. We actually learned that a way to break trust between the patient, particularly in the refugee community, is asking them about mental health. Just outwardly asking, are you experiencing depression or anxiety or any type of mental health concerns? The way that we would usually go about it with a patient who is of higher socioeconomic status or anything like that. It's actually a way to break relationships. And we were kind of like edged towards, there are certain topics, really try to stay on the topics that the patient brings to you, what they're comfortable talking about, because they're not only choosing to trust a complete stranger, but they're choosing to trust a complete stranger in a completely different world, essentially. So moving forward, the way that we can think about how socioeconomic status can create different health problems and even exacerbate existing conditions that individuals have. So for example, let's take individuals that might have to resort to living on the streets. Unfortunately, if you think about the conditions there isn't proper sanitation and hygiene. There isn't nutritional status. If you think about the food, they're lower quality in nutrition if they have access to food and clean water at all. And this is really just on the streets of in Canada and anywhere in Canada. I'm not even talking about the streets in a developing country, but in a developed country, living outside of a home, living outside of any type of building that can provide you with shelter, proper sanitation, proper nutrition, anything like that can really exacerbate current illnesses and even make acute conditions, like conditions that are only lasting for a short period of time, they can cause them to progress into chronic conditions. So if we think about some of the different things that people are exposed to, they can be exposed to various diseases, for example, tuberculosis, respiratory illness. Think about, I'm not sure if many of you are keeping up with the news. I feel like this pandemic has lasted ages, but thinking about now what's happening with COVID, thinking about how many homeless individuals are being exposed to COVID and unable to access adequate testing facilities or anything like that. And that's a respiratory illness. And one thing too about COVID that we know is, the more chronic conditions you have or the more risk factors you have, that can actually make your recovery and your prognosis a lot worse. As well, common things like the flu or hepatitis, hepatitis being if you think about the conditions of why someone ends up on the streets, for example, I know I talked about it being a spectrum, but let's go off with that example. If we're talking about hepatitis, we learned that the number one risk factor for hepatitis B and C is exposure to blood, and that would be from needle stick injuries. And, perhaps individuals that might be suffering with addiction, and they might not have access to, safe injection sites, or they might not have access to clean needles. All of these things are things that we need to consider as well. If we think about it, I talked a little bit about the nutrition, but if you think about it, how many people have read about, people that have gone on like all organic diets, or how much you walk into a health food store and how much supplements cost? Think about how much that costs just for someone who is middle class. Now, imagine someone who has access to very little income, if any income at all. Can they even find food every day? Can they even eat what it is required by our Canada food guidelines to maintain a healthy diet? And, I feel like this is preached all the time, but it's so true. What you put in your body is really how it's going to function. It's like a car. If you put, the cheapest fuel in it, your car's not going to run for a very long period of time. There's going to be issues on the inside. That's the same way that the body works. We want to put the best fuel in our body to get the best possible outcome. And unfortunately, for these individuals who have lower socioeconomic status, they're unable to do that. As well, we think about lack of access to medications or even a safe place to store medications. So many people who aren't even on a lower socioeconomic status are paying out of pocket for medications. As we know, there are certain medications that, aren't covered by OHIP that Not all of us have private insurance. There are many individuals that might have a chronic condition that requires medication and they can't access it. Or even if they do have a way or some type of funding to get this medication, think about it. There's some medications that have to be refrigerated, some that have to stay out of like direct sunlight. There's so many things that we have a privilege not to worry about when it comes to these things, but for many individuals, it is a constant struggle to try to keep their health as best as they can with such a lack of resources available to them. As well, something commonly spoken about is perhaps substance abuse. And there's often a huge stigma around substance abuse, people thinking that only people with addictions end up on the street, but many individuals that end up homeless might have undiagnosed, mental illness, and they're self-medicating with substances that they can find on the street. Many psychiatric medications are incredibly expensive, and they might not have access to it or access, let alone to a psychiatrist, a therapist, or any type of counseling for that matter. As well, if you think about it, often many things that we could take care right away, like a simple cut, or, we wash it out, we put a Band-Aid on it, we keep it away from any bacteria, it heals. Many people that are on lower socioeconomic status may not have this luxury. In fact, unfortunately, many people that, like I was saying, experience acute illnesses, acute injuries, they might progress to be far worse. We learn a lot about the progression of disease in like physician assistant school. And we learn a lot about how if something is caught early enough and treated, the patient can go on to live a healthy, normal life. However, how many individuals on a lower socioeconomic status basis have access to healthcare? How many individuals have immigrated to here and are not Canadian citizens, and as a result are struggling to find housing, opportunities for employment? There's so many different aspects that we have to take into account. And as well, I feel like I've talked about a lot, low mental health and high stress environments. We've talked so much about how stress can exacerbate, certain medical conditions. We've talked about the effects of cortisol and how that can change the physiology of the body. These are all things that we think about when we think about how socioeconomic status can impact current or preventable conditions that individuals might be facing. So if we think about it, many people think, okay, well, how does this happen? And when we think about access to healthcare, we say that this is a systemic issue. When we talk about systemic issues, that is what I was mentioning before, how there are certain policies and procedures in place, or there's certain practices that are approved and done that unfortunately limit access to certain groups or certain individuals. And that's what systemic means. It means it happens from, some type of policy or regulation, and as a result, it ends up affecting individuals. So it tends to serve the majority of individuals. However, unfortunately, because it's imperfect, it can't benefit and serve every individual. So there was actually a Canadian study that was done by Street Health that showed that the longer an individual spent on the street, the less likely that it was that they would have a primary physician. So I don't know if any of you have ever had to go through the struggle of finding a new family doctor or finding a family doctor, but it's not easy as it is. I know currently, family doctors are reaching capacity at their limits. I won't get into the funding models of the Canadian healthcare system, but healthcare professionals in Canada are funded through whatever, for us in Ontario, it's OHIP, whatever OHIP that is in different province, that's how we're paid and that's how we're funded. And essentially, if we think about it, individuals that, spend time on the streets, thinking that it'd be less likely that they would have a primary physician, think about all the different barriers that they might encounter just going to that appointment. How far is their physician's office? Can they walk there? Do they have to drive? Do they have adequate transportation to get there? You know, there are some procedures or some appointments that someone might have to do that requires someone to drive them home after. Do they have an adequate social system and a support system in place? And many individuals are further stigmatized and further marginalized, unfortunately, because of their living condition. As well, this study also showed that those that are presenting with a higher socioeconomic status and low health concerns, so maybe someone with pneumonia or someone with asthma, were offered appointments more frequently than callers from lower socioeconomic status who had chronic health issues. Now, we all go into healthcare, we're all very wide-eyed, we all really want to help and make a difference, but unfortunately, as I was talking about, no system is perfect, and there's so many different protocols and procedures in place that we have to follow to ensure that patients are receiving adequate care. And the reality of it is, an individual with a chronic health condition will actually cost more based on medications, investigations we have to order, different testing that has to be done, anything like that, you know, referring them to specialists than someone who presents with an acute condition. And going back to, like I said before, many individuals of a lower socioeconomic status often don't even have access to healthcare to treat an acute condition, which unfortunately leads to the progression of a chronic condition. So just some things to think about. 36% of homeless people we interviewed said that they had been judged unfairly or treated with disrespect by a doctor or medical staff at least once in the past year. These are quotes that are coming just from that study that I was talking about in the slide before. As well, 30% of respondents believed that they should be eligible for disability assistance. That is, they had a disability or serious illness that is continuous or recurrent and is expected to last more than a year, but we're not receiving it. So I won't get into kind of the definition of acute versus chronic, but when we think chronic, we think long term. And many individuals, as I was talking about, you know, funding and all of that, many individuals, there are certain resources through the government that can provide disability services, different, you know, monetary compensation, anything like that. However, many individuals don't have access to this, aren't aware how to sign up for this, aren't aware if they are eligible for it, because like I said, there is, when you think about socioeconomic status in that, you know, sliding scale, it's not homeless, living in a house. There's so many different circumstances in between, and many individuals don't know if they actually apply or if they're actually qualify for disability services that are available. So now we're kind of talking about what we could do as healthcare providers, what kind of care we can provide to individuals. And so what we try to operate on, the gold standard of when we see patients, is it's called patient-centered care. Essentially, there's different models that exist out there. You know, is it a paternalistic model? So the doctor knows what's right and we follow the directives of the doctor or healthcare practitioner, whoever it is. But what patient-centered care is, it's really thinking about that multifaceted patient. It's really thinking about when a patient comes and sits down in our office, in our hospital, our clinic, wherever we're seeing them, when they come to us, they're not just their set of signs and symptoms and their medical condition. They are a mother, a father, a teacher, a brother, a sister, their race. It's really important to recognize race, ethnicity, gender identity. These are all things that we need to consider when we consider who's sitting in front of us in the office. And that's why we really want to focus on patient-centered care, really ensuring that the way that we provide healthcare is centralized around the patient's wants, the patient's needs, and who the patient is. Something that we learn about when we're taking a patient history, you know, we obviously start off with, you know, what brings you here today? They tell you about why they're there. You get a little bit about if they've had any past medical conditions, but something that's an important aspect of the patient interview is social history. We're learned to ask about, you know, are you living in a house? Are you living in an apartment? Do you have an adequate support system? Are you married? Do you have kids? Are you a smoker? Do you consume alcohol? Do you use any illicit drugs? We ask all of these questions to get a picture not only about their medical concern, but also about their social status and who they are as a person. We call that taking a social history. And oftentimes, many people that see their healthcare provider, they just, nitty gritty, they're like, oh, my interview lasted like 2 minutes with my doctor. But that's really kind of the direction that we're trying to move towards, is we're really trying to get the whole picture. We're really trying to understand individuals as a whole. So when we're talking about the 8 principles of patient-centered care, that really just encompasses, respect for patients' preferences. Something that we talk about is we talk about the pillars of medical ethics. And essentially, one thing that we want to do is we want to respect the autonomy of the patient. Autonomy means that we recognize that the patient is competent and able to make their own decisions. What we as healthcare practitioners do is we are simply able to give the patient all of the information. We tell them the risks, we tell them the downsides, we tell them, the benefits of every procedure. And then as a result, we then say, okay, what do you want to do? How are you feeling about it? What do you think? We answer questions to clarify. And we really want to make sure that the decisions we make in terms of their treatment really respects what the patient wants and what the patient needs. As well, there's also the coordination and integration of care. That means, we don't just want to outline, this is the treatment, go ahead and do it. We really want to work with the patient to find treatments that are viable and available. I don't know how many people have talked about, I went to see my doctor and they prescribed me a medication that was like $300 a month. And they're like stressing, how am I going to afford this? And we as healthcare professionals, we are actually able, we can think about alternative prescriptions to give patients, medications that are funded or covered by the government. We can think about, perhaps providing samples to patients. There's so many different things that we can do to ensure that we're coordinating and encompassing care with the patient that is essentially an option for them. Because a lot of times we do see chronic conditions, and that's because it's non-compliance of medication. And it's not because the patient is, stubborn, but it's because they physically can't take their medication because they can't afford it, or, it's not covered by their job or anything like that. And, I was talking about information and education, giving the patient all of the information they need, really talking them through. If they're like, okay, what does an abdominal ultrasound entail? Being able to tell them, okay, when you go in, the technician will ask you to do this and this and this, and really giving them that information. And that ties in with, that physical comfort. Of course, there's boundaries and limitations we have to respect with all individuals, but physical comfort can really be given just with your words, looking a patient in the eyes, really empathizing for them, understanding that sometimes the moments that you don't say anything are the most impactful because they know that you're listening. They're not cutting you off with what you want to say, or you're not trying to say something ahead of them. You're really taking it in, listening to what the patient has to say before you react to it at all. Then if we talk about emotional support, because the scope of practice of PAs, it is so broad, certain physicians might want us to take extra time with patients that they know might be a sensitive case. Something we learn in one of our classes, it's called communications. It's where we learn all about taking patient histories and doing a patient interview, but doing that under different circumstances. One thing we have to learn how to do is how to break bad news. I had to practice. We have these things, these interviews are conducted with people called standardized patients. And what standardized patients are is they're just regular people. They basically are trained in how to act as a certain patient would, a certain disease pathology. And we get to practice on those standardized patients when we're doing these interviews, physical exams, etc. So I actually had to do a patient interview with a standardized patient. And I had to break the news that their 8-year-old son had leukemia. And I had to communicate with them what that entailed, respecting their decisions, making sure that we're getting all the information, but also being an emotional support. And even if I myself physically can't be that support, relaying them to resources that can support them and can be there for them. Something as well that we think about patient-centered care is involvement of family and friends. People's social support and social circles are so important when it comes to healthcare because it can help individuals and motivate them to seek treatment and go about that. And so
Sorry guys, Tori's just having an issue with her setup, I believe. So we'll see.
everyone, I don't know what happened. I think my internet just kind of crashed out there. Essentially, I was just really talking about, patient-centered care, the 8 qualities and the 8 principles. So that really kind of covers the end of the presentation. I kind of cut out almost the perfect time because after a few more bits of rambling, that concludes the presentation. So really, thank you so much for taking the time to log on and listen to me talk about social determinants of health. I'm going to open up the floor now to anyone that might have any questions at all. Feel free to put it in the chat or raise your voice or anything like that.
Awesome. Thank you so much, Toni. So we had some questions in the chat during the presentation, starting off with, so it must be really competitive, right? Referring to the PA program.
Yes, it is pretty competitive.
All right, and the next question was, are you interested in specializing in a specific field as a PA? And if so, how did you decide on that field?
So the way that physician assistants specialize is we apply to jobs within that specialty. So I'm actually considering specializing in family medicine or obstetrics and gynecology. And during my second year, I will go through clerkship, which is various rotations, and I will have an opportunity to find different placements and see basically what fits, and then I'll apply to jobs that I'll want to.
Awesome. So the next question was, what is something that PAs learn which MDs don't?
I honestly can't really speak to that just because I don't know what MDs learn. What they do tell us, though, is that our program was kind of molded and shaped on the curriculum as the MD curriculum at McMaster. Every school is different as well, but we're kind of shaped and molded based on that. We just cut out certain things just because we are only a 2-year program instead of a 4-year program or 3-year program. But yeah, I can't really comment on specific information.
Thank you. So the next one was, would you prefer CNA or MA as getting PCE or HCE? I have a lot of hours through being a home health aide, which is very similar to CNA.
I'm not really sure what the acronyms mean. Do you have any idea?
I don't either. I don't know if I'm saying this correctly, but Saloni Talati, can you please clarify on what you meant? The first question you asked, which was about CNA or MA. Can you see it in the chat if you can scroll up?
Yeah, I do see it.
Awesome.
Sorry, I didn't know if my mic was working. Okay,
It's
so I was wondering if for patient care experience, if CNA or medical assistant is more worth it for PA school.
So actually, to apply to McMaster's PA school, you don't need a single hour of healthcare experience.
Oh, wow.
I know for U of T, there's a set required amount, but really when I did my McMaster interview, I just talked about different experiences that I had in my undergrad. I do have some healthcare experience before I got into the PA program, but they really just want to see what kind of an individual you are, how you've kind of extrapolated certain skills from different activities and whatnot. So I really can't comment on what would be a better set of experience because I'm in a program where it's not a requirement.
Thank you so much for sharing.
Awesome. Yeah. And the next question in the chat was, is there residency after PA school?
No, there is no residency after PA school. Like I mentioned earlier, after you finish your 2 years of PA school, write your certification exam, you then go on to apply to jobs.
Great. So the next question was, you volunteered at the Hamilton Health Sciences and Patient Pediatrics Department. Did your interaction with these patients and families kind of make you more involved in investigating the role of socioeconomic status in access to healthcare?
I think it's definitely a contributing factor, but to say it's the one factor that kind of inspired me to go about and research it. I honestly, I don't know how to even answer this. It's such a hard question just because social determinants of health and socioeconomic status are so important in so many different settings, not just what I've seen in, volunteering at the inpatient pediatric ward in my undergrad, but also just in like certain family members or friends, seeing what they experience.
Yeah, thank you for sharing that. And the next question was, what are your opinions on telehealth or other non-legislative solutions to lower healthcare access disparity? And do you think that they will help?
I think that we almost don't have a choice in terms of COVID on moving towards telehealth. But one thing I will say, it definitely has its pros and cons. One thing we have to consider is in order to operate telehealth, you'd have to have access to a laptop, an internet connection, or a phone with a phone plan. And there are many individuals that don't reach any of those criteria. And unfortunately, that is another barrier that does restrict them from accessing healthcare. So yes, it might be more convenient for people where they don't even have to think about their phone bill. But for other people that think about the fact that they don't have any of these resources to access their healthcare provider and they physically can't go in person anymore, that's a huge barrier. So I think I'm playing devil's advocate here. It's great for people that can access this resource, but for those that can't, it's really not doing them any good, and they need that in-person physical place to go.
Yeah, that's a really good point. If anyone else has any questions, we are now finished going through the questions that were previously set on the chat. So any last minute questions before we start wrapping up?
As well, if you also have any questions, don't, like I mentioned it at the beginning, and just a shameless plug, you can also DM me on my Instagram. I'll put the handle in the chat bar. It's at the Ontario PA. And if you're interested in, being a physician assistant or what we do or what my everyday life looks like as a first-year physician assistant student, I post all about it all the time.
All right, we have one question. Advice to teens going to university majoring in some sort of sciences.
The advice that I would give to teens that are about to start university or thinking about starting university is pick something you're passionate about. If you really think you want to go into medicine, you don't have to go into sciences in your undergrad to do that. There are certain schools, whether it be MD programs or certain PA programs, that you do have some courses that are required, but you can also take those as electives. You don't have to make those your major. I went into biochemistry a little bit blindsided. I didn't really know what biochemistry entailed. I was like, I like biology and I like chemistry, so I guess that's kind of the fit for me. And it was so much harder than I ever thought it would be. And there's actually a lot of content that I really didn't enjoy and a lot of content I did enjoy. So I would say do your research and really try to be honest with yourself what do I like? What interests me? What fascinates me? And that's where you're going to excel in. When you're passionate about what you're studying and you're passionate about what you're learning, you're going to want to do well. The reason I minored in psychology was just because I was so fascinated about the human mind. Just like even talking to friends during my undergrad, they would say something, I'd be like, oh my gosh, that is like this principle that we learned in psych, and I was studying in my everyday life. But I was just passionate about it and I really enjoyed it. And I did really well in my psychology courses, just because I was so eager to get to the book, so eager to learn, so eager to keep going to class and exploring different things like that.
That's amazing. Thank you for sharing. And lastly, this is the last question before we wrap up. What major do you recommend for PAs?
I would recommend any major. I know that seems like kind of wishy-washy and you're like, okay, like, come on, like be serious with me. But to get into PA school, I can tell you for McMaster PA, the criteria is you need at least a 3.0 GPA on the OMSAT scale, and you need to be successful in your Cura Talent supplementary application. If those two factors are successful, you'll be offered an interview. If your multiple mini interviews successful or the MMI is successful, you're offered admission into the program. I know it sounds like kind of an easy formula and you're like, how do so many people not get in? Because your GPA does need to be competitive. The minimum 3.0 is the baseline, but really the more competitive your GPA is, the higher it is, the higher your chances are. But as well, you need to be successful in your Cura Talent supplementary application. And that was really just a supplementary application. It was both a combined video response and written response, where you really just get to talk about yourself, figure out if you're a good fit for the program, and then whether or not you'll be successful for an interview.
Awesome. Thank you so much once again for coming over and sharing this knowledge with us and talking about your experiences. Thank you to everyone who attended. I hope you got the chance to learn something. And yeah,